Good evening and welcome to Science Cafe. My name is Jenny King and I work in public affairs here at UT Southwestern Medical Center. Our team is proud to produce and host the UT Southwestern Science Cafe series. Along with my co-host, Charlie Thompson, and our many colleagues here at UT Southwestern, we thank you for joining us. Science Cafes are online conversations where speakers take you on deep dives into the science behind healthcare. As an academic medical center, UT Southwestern brings together research, health education, and patient care into one institution. Tonight, we have brought together a fabulous lineup of UT Southwestern women leaders to talk about the science, research, and care behind NEWBI, a new and unique program that serves our youngest patients. Amanda Billings and the founder of NEWBI, Dr. Lina Chalak, will get us started. Amanda will share about the Neuro Wellness and Brains of Infants program, which we refer to as NEWBI. The NEWBI program is research in action helping fragile babies in North Texas and beyond. Amanda works to expand resources so that NEWBI can grow. She will then turn to Q&A with the doctors. In addition to Dr. Chalak, Dr. Katie Hogue and Dr. Michelle Mackey will join us. They'll share how this new care protocol and philanthropy has made NEWBI possible. And as always, we will conclude Science Cafe with your questions. Before we start the program, I have a few housekeeping items to share. We're recording Science Cafe as well as live streaming it on the UT Southwestern Twitter page. Please mute your microphones. Thank you. As we are connecting through Zoom meetings tonight, consider leaving your camera on so we can see each other, especially during Q&A. And finally, while we cannot answer personal medical questions, we welcome your general questions about tonight's topic. Throughout the next hour, please list your questions in the chat. Charlie will address them after our speaker presentations. And now I am so pleased to introduce our speakers. As Vice President of Development and Alumni Relations, Amanda Billings leads philanthropic strategies at UT Southwestern to support the institution that encompasses hospital and clinic operations, 4 graduate schools, and numerous research labs and programs, including a recent successful capital campaign in support of the O'Donnell Brain Institute. Dr. Lina Chalak is UT Southwestern's Interim Chief of the Division of Neonatal-Perinatal Medicine and Professor of Pediatrics and Psychiatry. Dr. Chalak is also founding medical director of the Neurological Neonatal Intensive Care Unit, which we all know as the Neuro NICU. A physician scientist, she specializes in fetal neonatal neurology and developmental neuroscience. Dr. Chalak established NEWBI to support our region's most fragile babies with the goal of NEWBI becoming a new medical standard of care. Drs. Hogue and Mackey are graduates of the first in Texas dual training Neonatal Fetal Neurology Fellowship, which is here at UT Southwestern, and it is one of a handful of such fellowships in the country. Dr. Margaret Katie Hogue is assistant professor in the Department of Pediatrics. Dr. Hogue's clinical and research interests include vulnerable child syndrome in NICU populations and wellness and care for NICU patients, families, and care providers. She received advanced training in several pediatric fellowships at UT Southwestern, including Neonatal-Perinatal Medicine, Developmental and Behavioral Pediatrics, and the nascent Neonatal Fetal Neurology Fellowship. Dr. Michelle Mackey is assistant professor in the departments of pediatrics and neurology. Dr. Mackey's clinical and research interests include HI, or hypoxic ischemic encephalopathy, perinatal brain injury, congenital malformations, and the use of advanced imaging techniques to improve treatments for perinatal brain injuries. She completed 2 residencies in pediatrics and child neurology and advanced training as the first fellow of the Neonatal Fetal Neurology Fellowship. That is here at UT Southwestern. Welcome to you all. We look forward to this conversation. And Amanda, the virtual podium is yours.
Thank you so much, Jenny. And I want to say a big thank you to our Science Cafe audience here tonight on Zoom and Twitter and beyond. It is such a pleasure to be with you tonight. And I'm really excited to be here with my collaborator and friend, Dr. Lina Chalak. What you will hear from Dr. Chalak tonight is a story of hope and promise. But it's also a story of how community partnerships and philanthropy can accelerate medical progress. So I would guess that everybody with us tonight has been touched by brain disease in some way, shape, or form, whether it's personal experience, that you've had a family member who's been impacted, a friend. But I think all of us would agree that really there is no greater medical challenge that we face today than the brain. It's still often referred to as the final frontier in medicine. And the pediatric brain presents even greater challenges, but it also presents a greater potential for recovery from injury. And that's what we're really going to be talking about tonight. So in the Peter O'Donnell Jr. Brain Institute here at UT Southwestern, physician scientists like Dr. Chalak are laser focused on advancing more effective treatments and eventual cures for those who are impacted by brain disease. And we get really excited because we have the tools and expertise to study and understand the brain in ways that we could have never imagined over the last decade, but things have been progressing at such an incredible rate. But we still don't have enough with just the tools and expertise. We need community partners like the Crystal Charity Ball, and I see some of them with us here tonight, and other philanthropists who are stepping forward to invest in big ideas that really help change established paradigms. Dr. Chalak and her team members who are with us tonight are big thinkers, and you're gonna hear that when you have a chance to hear from all of them. They're helping advance research and innovations in care that are allowing premature and other fragile babies to not just survive and make it out of the hospital, but to thrive and have the best possible future. So I am very excited to now turn the virtual podium over to Dr. Chalak for her presentation.
Thank you so much, Amanda, and thank you to all of you who have joined tonight. What's a better, but there is nothing better than starting the new year with the first podcast being about the starts of life. And I have no conflicts to disclose. The support for newborn brain health is via NIH support as well as philanthropy, the Southwestern Medical Foundation and the Crystal Charity Ball. And I'm excited to tell you all about the intersection of science and philanthropy to make newborn brain health better. I want to start by a simple question. If you would engage with me and answer if you or someone you know has had a baby stay in the NICU. And the answers are just completed. We have we have over 50. So I'm going to stop the poll, and we have close to 80% of the community that has experienced a baby stay in the NICU. And that is not surprising. This is a topic that is close to all of our hearts. As a neonatal intensivist, I take care of the smallest and the tiniest and the most fragile of the babies. And we get better and better and better at resuscitating them. But now with the advancement of the science with the Brain Institute, we have the methodologies and the tools to understand the functioning of the newborn brain and how to optimize their outcomes and to improve neonatal brain outcomes is something that I'm very passionate about. To give you an idea of what we're talking about. So any baby who's born before 37 weeks is considered preterm. That's 1 out of 10 births. And it could be born couple of weeks early, or it could be barely made it into that first trimester. So we have those extraordinary low birth weight babies, 23 weeks of gestation, 22 even. These babies fit in the palm of our hands and they weigh about 1 pound. And the job is not just to resuscitate them and to give them life, is to improve the quality of their life. So think about it. These are critical time periods that the babies would be staying in the NICU instead of being in the womb. And it could be all the way up to 9 months. And I just want to take a minute, if you would think with me about how amazing and exceptional the newborn brain is. The rate of growth is unparalleled. There is nothing like this in our lifetime. The brain doubles in size during that critical year. And it's not just the size. if you see it here during that second trimester, the neurons are going to their final destinations. During that third trimester, we have the white matter coating that makes the neuron go faster and have synapses and connection. If you think about it, we're born with the same set of neurons, but the amount of connections and synapses and firing that happens is 1 million a second. So there is connections that are gone, they're pruned away. What we don't use is gone, and what we use is really developing and connecting with everything in the areas next to it. So just think about all this happening while the babies are under our care. What it means, it's an astonishing capacity for growth, for repair, for plasticity, and it's an opportunity for early interventions. If you recognize that somebody has a problem early, you have lots of plasticity and rewiring, and you could really use that and tailor that to improve the lifetime of outcomes for those babies. And saving vulnerable babies' brain, it's my life's work. It's not just my research. It's really, it's a privilege to be able to start that program at Parkland, where our most disfranchised patient population is, and to expand it and to make it standard of care, like Amanda has mentioned. So we founded this program at Parkland, and now with the help of philanthropy and support from UT Southwestern, we are expanding this program. To give you an idea of what numbers we're talking about, in the United States, every single week, over 8,000 babies are born preterm. 1,000 of which are those extremely low birth weight babies I told you about that can fit in the palm of your hand. And if you look at the numbers in Texas, that's even more, like 12% rather than 10%, which is not surprising. But it's not just about numbers. It's about the quality of life. And Preemie Voices is a book where those miracle babies have survived into adulthood and now are in their 30s and in their 40s. And a colleague of mine from Ontario, Canada, put their own testimonials into that book. So I put the link here for the Vimeo. You could listen to their stories, or you could get the book if you want. For me, every time I feel like I'm questioning my lifetime purpose, I open a page of that book and I just get inspired. And I want to read just one extract from one of those young ladies who's now in her 30s, who was one of the extremely low birth weight babies. She says, "Despite my petite size and aspects of my autism, I'm still proud to be me. I wear my differences like a badge of courage. I won the battle against prematurity, and if these mild deficits are the price to pay for being alive, then I can live with them." Well, the goal is to eradicate those deficits. And if we work together, all of us, I think we could do that. But it's just inspiring and amazing to see those babies, resilient adults, fully functional into our society. And now we could do even more. So this young lady was born at 27 weeks of gestation. Now we do 22 and 23 weeks of gestation. But let's get back to that program. I just wanted to give you my perspective and my why. Why do I care? Why do I do this? Now let's get to the how. And really the first engagement with community and philanthropy started when we were building the Parkland Hospital. We were fortunate to have donors and support to really have these individual patient rooms where the baby and the parents can spend some quality time. Before, they were all crowded, like 20, 30 bassinets in one room. And now each baby is considered as a full person with their room, their parents. And more important, we have an MRI scanner that we were able to install inside of the NICU. What it means is the babies don't have to move. They don't have to be transported to lose critical tubes or to get cold. It's a safe way to get all the information and to target all the therapies and to do all the counseling in the comfort of their own NICU. And this is something that we were very, very proud about and very fortunate to have the support to be able to do as we were building our new hospitals. To give you a perspective of what kind of system we take care of. So at UT Southwestern, it's not just Parkland. Parkland is our largest. That's the highest volume delivery, 14,000 births a year. But we also have our Clements University Hospital. We have our Children's Hospital where the babies get followed up until they're adults. And we have our Texas Health Presbyterian with expansion geographically north. All in all, this system that we serve, that's 20,000 deliveries every year, 1 in 20 births of Texas babies, 1 in 200 of the birth in the US, and really one of the few in the country that has both a fetal center that takes care of those babies before they're even born when they're having problems, a Neuro NICU program to take care of their neurodevelopmental issues during their hospital stay, and a follow-up Thrive program to take care of them after they're discharged from a multidisciplinary perspective. The mission is brain-focused care, family-centered, interdisciplinary. The goal is to improve neonatal brain outcomes. And it's not just premature babies. I focused on premature babies, but really we take care of babies with seizures, stroke, maternal substance use, infections, asphyxia, where the babies get deprived of oxygen during the delivery process. All of those babies, we have specific protocols, trials, studies, and a dedicated team to improve their neurodevelopmental outcome. It's a comprehensive program. It's not just the clinical care with the dedicated specialist. It's cutting edge innovative research. It's databases that cover from fetus all the way to 50 is what we're gonna plan to do with the new support that we're receiving. And it's that special training. We were able to found and establish a new fellowship dedicated to the newborn brain. So basically, after somebody trained as a neonatal intensivist or as a pediatric neurologist, they do an additional year under our supervision, just focused on the newborn brain. And Dr. Maki and Dr. Katie Hogue are our first inaugural fellows that are invited in the panel. You're gonna hear them with the Q&A questions, and we're gonna hear all about what they've done as far as research other than the clinical care. But what best to tell you about the program than one of our customers, one of our little babies. So you're gonna hear about the testimonial of one of our amazing cutting edge, tiny miracle babies born at the lower edge of like 25 weeks gestation. And she was referred to us when she had a brain bleed, and she has been followed up under our care ever since. Let's hear it from Miss Adley.
It's been phenomenal to go from where we were, 5 short years ago to now, to see where she is and how much she's surprised everybody.
I was in the hospital for 2 weeks, and at 24 weeks and 1 day, it was time. They were able to retrieve her twin sister, Avery, first, and everything went well, but then Adley had already descended pretty far. So unfortunately, they did have to
Dr. Chalak, we might be having a bandwidth issue.
Okay.
So if we want to just continue talking about the program while you bring that back up, we can do so.
I'm happy to do so. This is what happens when you use videos in your in your presentation.
Mm-hmm.
So the idea is, let me see what I need to do. Do I need to do a new share of my screen?
Yes. We see your screen with all of your many presentations on it.
Okay, I'm so sorry about that, y'all, but now you have a glimpse of my
live
real life.
Zoom. It's all good.
Now you have a glimpse of my real life. Should we go back to the video or should we drop the video?
I think we should just summarize the video. Yes, we can
Okay.
see your notes. There we go. Perfect.
Okay, great. So really, we're gonna summarize the video. Sorry that you could not see it. I might get to show it again at the end if we are fortunate. Adley basically is inspirational. She made it through her surgery. She started following with our specialist, pediatric neurology team and neurosurgery. Her seizures were treated. She started going to school. She walks with a little walker, and she is one of the brightest in her class. And I hope you get to see this by yourselves at the end of this session. I just don't want to jeopardize running the video one more time. So we'll just play it at the end if we are, when we're done and as we are answering the questions. But she's a summary of what the program does to those babies. They come to us, we take care of them, not just in the NICU, but after the NICU discharge. And there is a whole team of people that titrate medications, visits, early intervention to make the quality of life better for the babies. So what I wanted to do now is take you through some simple interventions with big impact, examples of what type of care we can provide with the support of this NEWBI program. Simple things that nurses can do at the bedside. We're going to talk about equipment that allows us to monitor the brain health. We're going to take a deep dive talking about innovation that we've made taking care of babies with asphyxia. And then we are going to talk about the special training of neonatal neurology. And it's a newly accredited fellowship that we've created that will allow us to have a generation of specialists in the pipelines to take care of those tiny babies and to improve their brain health. So let's talk about simple interventions with big impact. You see that first baby here. The baby is crowded, is uncomfortable. Look at the neck, look at the hands. That is not how a baby is supposed to be. This baby, on the other hand, looks like they are in the womb. They are positioned. So the way we trained our nurses, we have special certification around the special positions that the babies like to be in, respecting their sleep-wake cycle, understanding the baby's language, the pain scores. And even as we build these new hospitals, I've talked about the individual patient room, controlling light and noise has been tremendously important on those babies' outcome. And it's actually very interesting. Some of the hospitals in Brown have done studies showing that this has a very good impact on the baby's brain. But on the other hand, other studies done in the suburbs of Chicago where parents are too busy to visit because they're having to work during the day, showed that if you're in a single patient room and nobody's talking to you, those babies' brain are not doing well. So really, it's a matter of having the individual patient room and facilitating the parents or the support system and the interactions with the babies. For example, at Parkland, we have developed a beautiful program called Book for Babies. The medical students volunteer to come and read to the babies whose parents are not able to be at the bedside. And we follow up on their brain waves and on their MRIs and see how they're thriving. So this is just an example of simple interventions that we do at the bedside. Other interventions are nutrition. These babies cannot feed. They have to rely on, while they're very tiny, on parenteral nutrition in the veins. And we have a special nutritionist focused on neonatal programs that helps us put the right amount of zinc, copper. We know how folate is important in early development, the wiring of the neurons, the neuronal growth, plasticity, all of this is dependent on these trace elements and on very targeted nutrition. Another thing I like to talk about, we all love our coffee, right? So same for our premature babies. We've done trials and research sponsored by NIH that showed that caffeine improves their ability to remember to breathe, so they don't have apneas, and it's good for their lungs. But when we started doing the long-term follow-up, we discovered that irrespective of the apnea and remembering to breathe, caffeine really improved their neurodevelopmental outcomes. So now we have protocols for every single baby who's born preterm to be on this titrated medication at the right dose until they're over 32 weeks of gestation. Other things that we do with this program is real-time bedside monitoring. It tells us about the brain, oxygenation, perfusion, and this is in in conjunction with imaging, because imaging is a one-time deal, but the monitors, you see those cute, simple probes, allow us to get real-time continuous information about brain health. And EEG is one of those things that tell us about the brain firing of neurons activity, and it tells us if a baby's having a seizure. So you see here a full EEG. This is 10 seconds of the tracing. We have adapted the methodology to be amplitude EEG, which means that this is a compressed tracing, like an accordion. So basically, whatever you were going to have for 10 pages, you can have it here for 3 hours worth of one shot, because you compress the tracing like you would with an accordion. And now you see those sleep-wake cycle. Look at this. That fat portion, that's a baby sleeping right here. It's basically babies in sleep, awake, and the nurses look at those and they don't interrupt the baby in the middle of their sleep to do a feeding or a procedure. So this is really amazing for those tiny premature babies that are growing under our care. Near-infrared spectroscopy allows us to look at oxygenation and perfusion of the brain. And now that I've given you an idea of the simple interventions, the training of the nurses, the equipment that the program can allow us to have at the bedside for those babies, I want to tell you a little bit about innovation and research and how we make new standards of care. And I want to talk to you about neonatal asphyxia. Neonatal asphyxia is a condition that was thought to be only leading to death and disability. It's basically a baby who's growing well in the womb until something happens at the level of the placenta. And then you have lack of oxygen and blood flow. And usually those babies, like I said, are born with severe devastating consequences and have poor tone. And they used to have very, very severe prognosis, and a lot of them used to die. And when I was a resident like 25 years ago, the only thing we could offer is supportive care and treat their seizures. Well, we've come a long way in managing babies with birth asphyxia. And you think about their injury, the best way, because that I like analogies. So what happens is after we successfully resuscitate the babies, even when they come back and they have oxygen and everything looks good, at the level of their brain, there is flooding and reperfusion injury. And the analogy here is the hurricane. Everybody knows of the hurricanes, right? So when you have a storm like Hurricane Katrina is bad, but what kills people is not the hurricane, it's the flooding. When the levees break and you have flooding, it's the same thing with those babies. Even after we bring them back to life, we used to have this flooding of the brain with lots of perfusion, and the neurons are dying, but they're getting all that blood flow, and there is a whole cascade of events that leads to abnormal outcomes. So astute physicians in the 60s starting putting babies in buckets of ice and saying, well, now they're not dying. They're starting to have babies reported being alive. And then we took those observations into translational animal studies. And we did 20 years of research. We did piglet asphyxia model. This is a baby piglet here that we're doing chest compressions on. There's a cooling blanket around the baby's piglet. We're trying to see if hypothermia improved their brain outcome. And sure enough, it did. And we translated this into big research trials into the babies. And we have shown now with over 1,000 babies involved in clinical trials that not only you're improving their outcomes and they're not dead, but I'm going to orient you here. This is a relative risk. So 1 means no difference, and anything under 1 means we've improved outcomes with hypothermia. Look at those numbers. So we're having less cerebral palsy, less disability, less visual problems, hearing problems. These are not just babies that we're keeping alive. These are babies that are having a beautiful, normal life afterward. For every 6 babies that we treat with hypothermia, we could prevent complete abnormal outcomes in, for every 6 we treat, we have babies that we prevent to have a normal outcome. So 25% risk reduction, 1 out of 6, completely normal outcome. And now after this cutting edge research that we have done with NIH support, we have shown that there is cooling within 6 hours for babies that are having the encephalopathy and the birth asphyxia can prevent abnormal outcomes. So basically we keep their temperature for 33.5 degrees Celsius compared to normal baby's temperature, and we keep them under this cooling blanket for 3 days. And we monitor them with EEGs, and then we send them home, usually within the first week of life, and they're doing superb, and we follow them up in our programs. And not only that, the early trials that I told you about where hypothermia became standard of care was in 2005. And we knew that while we originally focused on babies with moderate and severe asphyxia, once we proved that it worked, we really need to go for babies with less severe disease. And that is exactly what we're doing. We've started looking into those babies and seeing that even those with mild brain injury, with mild asphyxia, they can have like subtle deficits. They don't have death or disability, but they could have behavioral functioning, attention, memory, these subtle deficits that we want to eradicate. I just got a new grant for a new study, Cool Prime, and I've got 15 sites that have joined us to look into what's the best way to provide therapy for those babies with mild asphyxia. And we engaged the parents and the community to find out what's the best way to design the study, what are the important outcomes, what kind of consent we would do. And we published with our engagement with the family. We went through these surveys, and over 400 participants that were either having a baby with asphyxia or were themselves survivor of mild asphyxia, they told us that they do not want tossing of a coin randomization. So we did site-specific allocation for the trial, where each site has a practice, and we compare the practices to determine if hypothermia can change the outcomes of those babies with mild asphyxia. So this is very exciting. That new trial will launch in the summer. We are now preparing all the sites and training all the sites, and we look forward to answer on those babies so that we could prevent deficits altogether, not just the babies with moderate and severe asphyxia. Other things I wanted to talk to you about is we have cutting edge research with MRI. I have this new brain health monitor. I've got a new sponsor with NIH where we integrate data from all bedside devices into these devices that look like what the weather report would give you. Well, it's telling us about brain health, and really it's integrating all of those biomarkers and looking into signals with complex duration over days. You see here on the top screen, and complex signals over all the frequencies, not to make it complicated for you, but the neurons and the brain is firing at different frequencies of oscillation. And now we could get all those complex signals to be visually interpreted at the bedside to give us real-time tracking of that flooding phase. Remember what I told you about the hurricane? So we were able to see it while the baby is resting and have a comfortable hat. We're able to see all those signals, and then we get the MRI and we get them into early interventions and therapies. In the last piece of the presentation, I do want to talk to you about the advanced training and that special fellowship that we've created because our fellows are now faculty. We've retained them. So not only they have special training in the newborn brain, but they joining us in the ranks so that they can train other people. And you're gonna hear from Dr. Maki and Dr. Hogue in the panel today. Dr. Maki was trained originally as a pediatric neurologist, and then she did the additional year focused on the newborn brain. And then Dr. Hogue was trained as a neonatal intensivist and a developmental specialist. And then she focused also on the newborn brain with that special training. And now we're getting the, along with a couple of other programs in the country, we're getting the program accredited so that all of the hospitals also will have it as a standard practice and standard of care. I want to tell you a little bit about Dr. Maki's project. When she was a fellow, she was looking at these advanced MRI images and looking at the brain volumes that to help predict the neurodevelopmental outcomes for our babies when they're 2 years and school age, so that we could predict those with early interventions. And Dr. Hogue, I want to tell you also about her program. She was really interested in the families of the babies that we care of. So the care is not just the baby. The sick baby also endangers the family dynamics, and the parents are worried, and they have a tendency to treat the baby with a vulnerable child syndrome, not like all the other babies. And she has a new trial for cognitive behavioral therapy, where we train the parents to think about the feelings, the actions, the thoughts, and because what happens after hospital discharge is just as important as what happens in the NICU, if not more important. So we're empowering the parents to take care of our premature babies and our vulnerable patient population. The vision here for this program is to help our fragile babies not just survive, but thrive. And we want to prevent and treat every single baby at risk for brain injury. This is not just the preemies. Everyone is at risk. We want to be a model for improving newborn brain health everywhere. And we could do it with the support of philanthropy, like the Crystal Charity Bowl Award, and with the help of NIH and science and community involvement. And I want to, I told you we're a multidisciplinary team. Our pediatric neurosurgery colleagues have March 4th, sponsored by the O'Donnell Brain Institute, a symposium where everybody is invited to discuss advances in the pediatric neurosurgery. I'm going to be a speaker. Dr. Brett Whitmore, one of my colleagues in the neonatal neurology program, will also be a speaker, and multiple others. So feel free to look at the information provided. I also want to tell you, March is a special month. We have our Thrive program, where we follow up our babies all the way into adulthood. And March 4th, we celebrate them. If you go on that website, lowbirthweight.org, you can actually register. You're invited. There is an Award of Hope yearly celebration. There is lots of dancing. These are our ex-premature babies, showing you that not only they're living the life and thriving, but they can dance and have some amazing moves. And I have to say, none of this is possible without a team. And I am fortunate and blessed to work with the very best team possible. And at UT Southwestern, I've got the support to launch this program. And it's really amazing to see how far we've come. Started with an N of 1, and now we have a village. We have nurses, nurse practitioners that are not even mentioned all in the pictures. But to give you an idea, we have pediatric neurosurgery, pediatric epileptology, neuroradiology specific to the newborn brain, people from the Autism Center, the Peter O'Donnell Brain Institute, and really it's a village that we have that is focused on newborn brain health and on taking care and focusing on those babies. And without anything more to add, I would like to open for questions from the audience. And it is a real pleasure to be able to share with you the success and the launching of our program.
Thank you so much, Dr. Chalak. And as people are submitting their questions, please feel free to put those in the chat. But I'm going to take just a few minutes to just do a little bit of a deeper dive into a few topics that you brought up in your presentation, Dr. Chalak. And I also am excited that Dr. Katie Hogue and Dr. Michelle Maki are going to join us for this part of the conversation. As you heard, Dr. Hogue and Dr. Maki completed the Neonatal Neurology Fellowship Program, and they are now UT Southwestern faculty. So just really showing what an amazing pipeline that is for us to get these incredible experts serving babies in North Texas. So Dr. Chalak, I want to start with you. You mentioned that Newbie is the first program of its kind in Texas and one of a handful in the country. I think I've heard you say there's only about 5 programs like this in the country. But what that means is that you're really on the front edge. You are delivering what is not yet considered to be standard of care. A lot of these are research interventions. And so my question to you is, why does this make philanthropy so important to expand a program like Newbie?
So I think philanthropy is essential because people have other programs have perhaps small aspects of it. So they either buy the equipment, or they have the clinical program, or they have the special fellowship, or they have research. Very few programs in the country have the ability to do all of the above. And doing all of the above requests support. NIH funds studies that are trials, that are research-based only. But to get the equipment the babies need, the training of nurses, the training of the fellows until the fellowship becomes fully accredited and standard of care, where you cannot have a program if you don't have a fellowship. We're still years until that happens. Until that happens, we have to depend on the community, the support, and the academic environment to be able to develop these novel concepts and these novel ideas to make babies' lives better.
Thank you so much. Well, I'd like to turn to Dr. Maki. Dr. Maki, so good to see you. The fellowship program that you and Dr. Ho completed is a unique dual certification opportunity. And again, something that's really first in Texas. Can you give us an example of how that's training prepared you to care for these fragile babies in a way that a single certification would not?
Yes, absolutely. And let me start by saying I'm so excited to be here with everybody tonight and to get to talk about this passion that Lina and Katie and I share, which is taking care of babies all day. And the training that I received at UT Southwestern and this fellowship has allowed me to do that. So looking back, what we do is really kind of new. If you think about the field of neonatology, which is the specialized medical care of infants, it's really had its birth in the last 5 or 6 decades. And what my predecessors realized over that time is how critical brain health and early targeted brain-centered care is important to the newborn infant in terms of long-term neurodevelopmental outcomes. And so most people don't realize that this field exists, this fetal and neonatal neurology. What we're doing is really caring for the baby brain from the time of conception all the way through early childhood and beyond. And it's really such an expansive discipline. So we work to understand during all those periods of development, like Dr. Chalak showed you from that Time magazine picture of that woman pregnant into the NICU incubator, at each time point, as things could go wrong and cause disease, that's the area of the specialty. And so after completing my 5 years of combined pediatrics and neurology residency, I focused for a full year just on baby brains with extra training in advanced neuroimaging techniques, where I focused my research, working closely with Dr. Nancy Rollins, who used to be head of our pediatric neuroradiology division, focusing on how to manage specialized seizure care in infants, physical medicine, and early childhood neurodevelopment. So in that light, now I take care of babies with brain injury, with seizures, with brain bleeds, and a significant focus on these high-risk premature infants as well. So for example, I might consult on a pregnant mother and father during the pregnancy if there are brain differences diagnosed early on, and then meet the baby in the NICU as soon as they're born, and follow that same baby and family through my early childhood neurodevelopmental clinic. And so my specific training and this certification really has provided me kind of the very unique tools. Like we said, this is one of a handful of programs in the nation right now. And so not only the medical aspect, but also I learned from my mentors, one of the most important things, which is how do we communicate to families? Because for most families, being told that your baby has a brain disorder, something's wrong, is the worst day of their life. And so I consider it my job, even more than the medical knowledge, to ensure that those families feel cared for through the whole process. So I hope that answers the question.
Oh, that was great, Dr. Maki. And I want to follow up on something that you mentioned about being able to follow these babies and see them into, their childhood, and, that continuity of care is so important. But also the fact that, a lot of them have been on these research protocols, and to be able to really look at what are their long-term outcomes is so important. So I want to pose a question to Dr. Hogue. Tell us a little bit about how you follow these babies throughout their childhood to see if they need any additional support as they grow up, and especially maybe touch on the Thrive program.
Awesome. Thank you so much for having me here today. I'm super thrilled to be able to talk to you and answer so many questions if you have them. I am so grateful for this fellowship because it is truly unique in the entire nation. UT Southwestern in this program is one of a kind, and I truly mean that, one of a kind. We have programs like the Thrive Clinic, like Dr. Chalak and her colleagues have set up within the neonatal NICU program that are not replicated anywhere else in the country nor the world. And I say that because we have unique clinics that follow up babies after they leave the NICU, which is the one that Dr. Mackey works in, but also the Thrive Clinic. And so if you aren't familiar with the Thrive Clinic, that is the little invitation that you saw, where we follow babies that have been in the NICU with high risk diseases, and we follow them up until 5 years of age, which is incredibly rare. And really, what's also rare about this program is that it's developed in a primary care model, which means that we are the general pediatrician that is subspecializing and focusing in on these developmental concerns, behavioral concerns of the children. And we have a specialized knowledge of knowing where they've come from. So I work in that clinic. I was trained as a neonatologist, focused on learning more about the neonatal brain, and then also development and behavior for these children. And so what we also are noticing is that while the brain has a very critical period of development within utero or up until delivery, up until 5 years of age, the brain is still remarkably making new connections, and it's an incredible time of growth. And so early intervention and early identification of any types of stumbling blocks or hurdles that these children might have in terms of learning or behaviors or development, we can pinpoint those early on and get them access to resources. And so it's a life changer for these children. And having that as a primary care model really makes that make sure that we are able to follow these patients up. We have 98% follow-up rate. So we really keep a track of these families, and they love us and we love them.
I want to say, we had one time a family that couldn't make it to an appointment. Our follow-up person who really trained Katie to do the follow-up in that Thrive program went to was it Mexico that he traveled. He just used his own Southwest money, and he traveled to go see them and do the follow-up. So we take our job very, 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 very seriously, and that's the way to do it. You cannot just, and to me, the proudest piece is we take care of the most disenfranchised patient population at Parkland, and we're doing almost like reverse. So now we're expanding with the support from the Crystal, with the new support. Actually, we're now moving to all our hospitals on campus. So reverse discrimination, so to speak. And that makes me just happy. I don't know if it's politically correct to say that, but it makes me very, very happy to be able to do that. I don't know if you guys think we want to give a trial for the video? There was one question on that. What do you think, Amanda? There is a question about the mild HIE. We could cover all the questions and then try the video. I'm optimist. I want them to see her story.
Well, let's open it, Dr. Chalak. I think we're going to open it to a couple of questions from the audience, and then we do have a link for the video. If we can't see it, we're going to make sure you all have it and you can watch it on.
Okay, perfect.
Thank you, Amanda, Dr. Chalak, Mackey, and Hogue for your presentations in this conversation about NEWBI. Now let's go to the audience questions. And our first question was submitted in advance and is for Dr. Chalak. This question connects directly with your presentation and remarks. What is the ideal brain development environment for babies once born?
The ideal brain development is the womb, obviously, until term. And when that is not possible, then a NICU that has that Neuro NICU concept. And I want to emphasize the Neuro NICU concept is a brain-focused intention and attention to care. So even if you're poor, and even if it's not the fanciest intensive care in place, you could still educate people. You could still train nurses. So it's not just equipment, it's education, teaching, outreach. We do a lot of that, and that is essential and important. The nurses spend the biggest amount of time at the bedside. So if we just do physician stuff, then we have not done anything. We have to have the nurses on board. The other people that are the most important are the parents. So if we do this amazing, wonderful care, and A, the parents don't understand why, or two, we're not able to follow up or follow through with them or empower them. And I think that's where Dr. Hoag's research about empowering the families become important. Then we have failed those families. So brain care and brain health is not just buying equipment. It's that comprehensive program. It's basically the education, the care, the training, the multiple team approach. It's everything you do when you do rounds or care for those babies. How does it affect your brain? Even when you're putting a breathing tube for breathing or a feeding tube for feeding, every single activity that we do, we ask ourselves, how does it affect the baby's brain? And I think it's that comprehensive model, the partnership with families, foundation, the support of the institutions, having all the team members, not just the physicians, be key players is really, really important.
Thank you. This next question is directed to Dr. Mackey. This question comes from Karen Downing. This is such an interesting topic, she says. What types of interventions and improvements in care have led to the best outcomes so far?
You know, I feel that's a wonderful question. Thank you, Karen Dowling, for asking us that. I feel like we could do a whole nother hour in all of the research and advancements that the field has brought to the baby brain so far. But one of the things we're most excited about is how therapeutic hypothermia, or cooling the baby brain right after brain injury within the first 6 hours of life, has made remarkable improvements in babies in terms of their morbidity or mortality, or really improving the rates that, you know, they're not dying, and seeing that their development long-term is improved. And so we're super excited, all of us in the Neuro NICU team, to be working with Dr. Chalak, who's spearheading this immense effort on the Cool Prime study to look specifically at babies with mild brain injury or mild encephalopathy, and looking at this specific group of infants who've not been previously addressed, to see if this treatment will work for them also, which could lead to huge advancements for thousands of babies around the world. So we're super excited to be involved in that research, but there's tons of other things going on. That's one of the things that's most exciting for us.
Thank you. This next question comes from Christine Fossey. Her question is, the partnership with families is essential to best outcomes for children. What are some of the things that parents can do to improve outcomes besides being present?
That is a good question. Who do you want to answer your question?
I'd love to answer that.
Okay, go for it, Katie.
That's a fabulous question. And it really hits home for all of us, particularly with my area of research. Families are so important and integral. I don't like to think of our patient as just being the baby. It really is a unit of the family surrounding that baby. And it is our job as neonatologists and brain specialists to really focus on that special bond. And so how do we help create that? Because the NICU is automatically a different type of environment than what a parent would naturally hope to enter into the world or welcome their baby into the world for. And so we really try to have parents present for cares in the NICU just to start that bonding and attachment in any way possible, anywhere from like diaper care changes to any other thing that we're trying to do to help the baby, reading and talking to their baby, even leaving like a little piece of cloth so that the baby can smell their parents is really important. There are different senses that really create that attachment, and especially kangaroo care, which means if you haven't heard that term, it's basically having the parents be able to hold their baby skin to skin. So it really creates that bond, that attachment, helps with even breastfeeding. So that's important. But I will also say that switching it back onto us, that it's really important for us to be able to focus on that family and make sure that they're supported, because there's a lot of things going on in the NICU. Parents have tons of worries on their brain every single moment. And so how can we take that onus onto ourselves to give them supports, from mental health support, because it's very natural for families to have feelings of anxiety, sadness, and hope too. And so how do we give them the opportunity to express those feelings in a non-judgmental way and hook them up with resources that they need? And so that's the focus of my research right now, in creating that new standard of care to incorporate that into our NICU care. So that's something that our program is really championing right now. So thank you for that question.
And I mean, really the interventions, the reading, encouraging them to read the books they like, the music they like, this is what the baby was supposed to be listening to in the womb. And then you could replicate that outside. So that precision targeted approach, not reading them all the books that we think are good or the music that we think is pertinent. We have families, the nurses know how to suit them. The parents pick something, and this is the something that sticks. It's really amazing. We have a violinist at Children's that come and plays for the babies sometimes. I see one of our preemie moms, Adriana Ramirez, and her baby, a 22-weeker preemie, is here with us. I have to say, nothing makes us happier than satisfied customers, and they're thriving. I think that is the piece. It's a message of hope. And I think it's a message of hope that is possible because of the community support and the education and the outreach programs and the intersection of science and philanthropy. It's the way to do it. And we're just so thrilled about this new program starting and about the support for that new program.
Thank you. What resources are there for lay people to learn more about neonatal neurology? And Dr. Chalak, I would like for you to answer that question. And then Dr. Hogue and Dr. Mackey, if you have anything you would like to add, please do.
Okay, so I'll tell you, I put the Preemie Voices, that book. I love that book. It's because they're telling you their story. What's more inspiring? So to me, that book is for us, not for the babies, but really they just inspire us to keep trying to do better. And there is a Vimeo link for that. All our references, if you look under my bio and the team's biography, we have all the references for the cutting edge research, for that Cool Prime study. There's lots of questions about it. The Neuro NICU program, we have a web page. We have the neonatal neurology page on our UT Southwestern link. And happy to put more of those references. I see that we're catching up with those. And there was a question also, I also want to make sure to address it. Somebody in the audience was asking me, can the adults get cooling too? And absolutely yes. If an adult has traumatic brain injury or a cardiac arrest, they also can get cooling. But I will tell you something. They don't have the exact same excellent response as we have in the babies because of the plasticity and the repair. So it just tells you we're tapping onto something here. I mean, the newborn brain is unique. The amount of response that you get because things are in the process of forming is just better than anything we would get in an adult. But yes, we do this for adults, and yes, they respond too, just not to the same extent.
Thank you. I have one more question that I would like to add, and it's for Amanda. Amanda, how can grateful patients learn more about becoming a volunteer or a donor?
Sorry, let me get off mute here. So you can visit our website, engage at utsouthwestern.edu, and you'll actually see stories of people, a lot of our patients who become partners and really helping be ambassadors for these programs. And also, coming together to help advance the research, which as Dr. Chalak and Hogue and Maki talked about, it's always pushing the envelope. What can we do better? So that's really, again, a partnership that we have with so many people in the community that makes that possible.
Okay, I'm going to take over because we are at time, but I do want to let everyone know that if they'd like to stay on for a few minutes after we do our thanks, we will try again with the video. And if it doesn't work, we will post that link again in the chat so everyone can click on it when we hang up and watch it. But what a fabulous conversation. I'm just inspired. Thank you, Dr. Chalak and Maki and Hogue and Amanda for bringing this to us today. It's incredibly heartening to see this research put into action and to know this is happening here in Dallas at UT Southwestern, Parkland, and Children's, and that you're working with people around the country. And I know we're motivated by the hope that Newbie gives us, that our most fragile babies will have the chance to grow up and make the world a better place. And I did not cry when I said that, so I'm really proud. To everyone tonight, thanks for joining us at Science Cafe, engaging with us. Be on the lookout for future emails about Science Cafe. And we have select community programs as well, like the Black Men in White Coats film event next Friday, February 3rd, here on campus at UT Southwestern. My additional thanks to Charlie and to our colleagues, Dr. Lisa Dennison and Mark Flores from the Development and Alumni Relations team for helping with tonight's program. So good evening all, and we're adjourned, and we will now try to play the video. Thank you so much.
It's been phenomenal to go from where we were
They
5 years ago to now, to see where she is and how much she's surprised everybody.
I was in the hospital for 2 weeks, and at 24 weeks and 1 day, it was time. They were able to retrieve her twin sister, Avery, first, and everything went well, but then Adley had already descended pretty far. So unfortunately, they did have to kind of jolt her out. With that came a lot of brain injury. Hi, baby. Oh, good. Her diagnosis was intraventricular hemorrhage, IVH, grade 4 on the left side and grade 2 on the right. Because of all of that damage, it left her with cerebral palsy. We were moving to Dallas as soon as we were discharged from the NICU at 4.5 months. So they referred us then to Children's in UT Southwestern.
This neonatal neurology program is quite unique. The concept started because of the realization in the need that the newborn brain is not like the adult brain or even the child brain. I've started focusing my research on this for the past 20 years. I've met Dr. Machi when she was a resident, and she wanted to take care of the newborn brain and specialize in neonatal neurology. So she was the inaugural fellow that we've had in the program.
Towards the end of my training, my peers began to refer me for consultation, babies who were premature or had brain injury. And that's how I met Adley. She presented to the hospital with seizures related to her premature brain injury. This type of care that Adley is receiving through my program is completely new and unique, and we are so blessed that she was able to benefit from the training that I received. She is now just thriving. She is in school, she is reading on grade level, she is extremely intelligent, and while not walking independently, she is now walking with assistance of a walker and is working on her way towards independence.
We are the only such clinical program in Texas, and we are one of less than 5 in the country. And now we want to expand it from Parkland to all our 4 hospitals on campus to know that the patients receive the best of care even the most underprivileged, is something that really should make every single one of us involved proud. This particular concept could not have materialized if I was in any other environment or space than being at UT Southwestern.
The doctors that we've had at UT Southwestern at Children's, they never gave us a grim prognosis. They always just said, we just have to follow her lead. And that was scary, but then also encouraging that there is a bright future out there for her.
Her resiliency is probably the biggest thing she's taught. She's never let anything stop her. The sky's the limit for her, and I'm excited to see where we're at in 5 more years.